A very good evening, and at the outset, I would like to thank the organizers, Dr. Puneet in particular, for having me here. It's a great opportunity as always. May I now invite my elite panelists. I really have a very well-informed senior panelists along with me for the discussion today. Dr. Balachandra Kashyapi, Senior Uro-Oncologist from Pune. Dr. Ginil, Senior Uro-Oncologist from Amrita Hospital, Kochi. Dr. Anup Kumar, Head of the Department of Urology in Safdarjung Hospital. Dr. Kapil, Medical Oncologist from Nagpur, and Dr. Renu Madan, Radiation Oncologist from Chandigarh. Welcome all. So we have heard the presentations of the abstracts and a brief SWOT analysis as well about these abstracts. I would like to take it a little more further and see if we have answers to a few questions. This was the, I am starting in the reverse order for some strange reason. Anyway, this was the trial which showed a combination of nivolumab and ipilimumab did not actually do well in patients receiving adjuvant immunotherapy. So it brings us to the trial which approved adjuvant immunotherapy to be beneficial in patients with unfavorable characteristics of RCC. So we go and refer to the Keynote 564 trial where pembrolizumab was used and was found to be useful. So, sir, my question to you is regarding the Checkmate 914 trial. We have always been taught that PD-L1 expression is very important for a utility or benefit of immunotherapy.
Yeah.
But the Checkmate 914 trial did not look at it as a factor of consideration at all. What are your thoughts?
Yeah, sir. In Checkmate 914, only around 10% of the patients had the PD-L1 above 1%. And in contrast, the standard, like what we consider Keynote 564, that had around 70% of the patient with the PD-L1 level more than 1. So that may be the factor,
Yeah,
one of the
that
factors.
have impacted the outcome of the trial?
That may be the one of the factor, but it cannot be whole factor. Probably it's a poor marker per se.
But do you think that it is really relevant that we look at PD-L1, because we have a lot of talk now saying it really doesn't matter if patients have PD-L1 expression, they do better. But regardless of PD-L1 expression or PD-1 expression, they will still respond. So what's your take on it?
It may contribute to the usefulness of immunotherapy, but it is not the sole determinant for the efficacy of the treatment and improvement.
Okay. Any opinion from uro-oncologists? Would you like to ask your patients to have a IHC done before he reaches your medical oncology?
In kidney tumors, usually PD-L1 expression is not routinely checked, like in a bladder or urothelium. So at present, what we have is pembrolizumab, and probably with the extract trial insulin in some patients. Other than that, there is no useful materials in the clinical practice. This one is actually, we can consider that is a negative trial.
It's a negative trial, yeah. Sir, again to you. What is your take on Keynote 564? Is the data strong enough to start recommending adjuvant immunotherapy on all patients with poor risk characteristics?
Data looks promising, but we do not have the overall survival data, fully mature data. So in even NCCN also recommends, in of the cases which have the high risk, we may proceed with the adjuvant pembrolizumab.
Okay. So when pembrolizumab yes, sir. When I'll continue till sir, yeah.
So one quick question I wanted to ask you. In these studies, they have clubbed adjuvant after partial and adjuvant after radical also.
Adjuvant largely after radicals.
Yeah, but this group which has been studied includes even those patients where partial has been done. So my question to the learned panel is that we don't commonly consider a adjuvant utility after you've done a good partial. So is this a practice which is very common, or is it the data is just telling you that it is not going to benefit you much if you use adjuvant after a partial?
We have given adjuvant after partial also if it is fitting into the criteria.
Yeah.
eligibility criteria like high grade or a venous sinus, segmental vessel involvement is there. Something is seen. We have suggested like it can be sinus invasion sometimes. So these obvious things are there in the partial also. We have suggested a adjuvant, but majority of these patients, adjuvant versus observation, majority of the patient for different reasons, they just went, but a few had gone for adjuvant pembrolizumab.
Yeah, overall, so to speak, the data on adjuvant systemic therapy is not very robust. Sir, this is another question for you. When pembrolizumab worked, why is the combination not working? Why is this discrepancy?
Yeah, as Madam has already pointed out, that the PDL1 positivity was around 10% in the Checkmate 914 as compared to more than 70% in Keynote 564. Also, the sarcomatide component was very less. That was around 5% in the Checkmate 914, and that was on more side in the Keynote 564. That may be the one of the factors that has shown the discrepancy. Other things is because I think the dose of ipilimumab, so we had in this trial, they had used 1 mg per kg every 6 weekly. And what we have used in lung and other melanoma trials, that generally it's a more like condensed, like it's given 3 weekly. So that may be the one of the thing. Also, this trial has given only 6 months of immunotherapy as compared to the 1 year of Keynote.
I have a question, Santosh. Will you look for PDL1 in kidney tumors at all in your routine clinical practice? You will not routinely. Okay.
Yeah. So, sir, another last question for you. There were a lot of adverse events. We have already gone through them. Do you think that you can really see using a combination immunotherapy in the adjuvant setting, even in the distant future, considering the extent of adverse events? There were 4 deaths in the trial group.
Almost 30% of the patient had grade 3 and above toxicity.
Yeah, 38.
So that looks for a patient who underwent surgery. They may not comply that as the disease has already been removed. So why to go ahead with the immunotherapy? So because of the toxicity, we may be.
Yeah. So looks like adjuvant immunotherapy is not on the cards, at least in the immediate future. But then sunitinib is a much easier drug to prescribe for the urologist. So the next question is for the urologist. Sir, Anup sir, will you routinely offer adjuvant sunitinib therapy for your poor risk patients of RCC?
So we do not routinely prescribe the adjuvant sunitinib, but yes, suppose it's a locally advanced tumor, we found there's a thrombus in the IVC. It's a high risk category like sarcomatoid. So poor risk category patient, we have prescribed sunitinib, but this is not under the guidelines. No guidelines till date recommends the use of adjuvant sunitinib or pegylated.
Yeah.
So this is in an experimental trial. We have used it, but very less data to show the response.
Yeah. So as we look at this publication which was published in the Journal of Clinical Oncology in 2023, the long-term evaluation of patients who were commenced on adjuvant sunitinib based on the extract trial and then on the Checkmate 564 trial of pembrolizumab showed that with advancing follow-up, the benefit started reducing considerably, meaning to say that what was initially seen as a favorable response actually did not sustain over a period of time. So this is a very important paper, and that also tells us that a complex combination of various trial designs actually play a crucial role in how we interpret the results. It could be the problem with assignment of the patients either into the experimental group or the control group. We may not have an appropriate control. We may not have a valid surrogate. Then there might be a bias, forms of informative censoring. then we do not have plan on the optimal post-progression therapy. So, the data on adjuvant therapy is actually very, very weak, inferior. This is the second paper that was discussed, off-clamp versus on-clamp robotic assisted partial nephrectomy. It was a systematic review and a quantitative synthesis. A lot was said about it, but then what was found was that there was really no significant variance in the percentage decline in EGFR. There was no statistical difference in length of hospital stay, complications, but though they mentioned that the conversion to open or radical surgery was actually low, it was relatively higher in patients off-clamp, and the blood transfusion rates were also higher in the off-clamp group. Surprisingly, significantly lesser positive surgical margins were noted in the off-clamp group, probably a statistical error. I do not see any rationale in this result. This is the second paper, something similar from our own Gopal Sharma, which showed that off-clamp robotic assisted partial nephrectomy actually did not result in a better renal function preservation. Again, now coming to the questions. Kashyapi sir, the primary outcome was EGFR. It was not altered in the study. Do you think this itself is a good case enough for us to discard the off-clamp technique? Forget about it.
I don't think so. In a selected suitable patient, small tumors, as Dr. Taneja was saying, somebody with a CKD, if you want to restrict your ischemia time, you should be able to, whatever you are comfortable. You need not discard it.
Need not discard,
but need not insist only on a off-clamp.
Yeah.
You should do what is safer and what is good for you, for the patient and in your hands.
Ginil sir. So in these studies, none of the general parameters which were evaluated achieved a statistical significance. Do you think that there is any relevance to these studies? Should we be doing more such studies, or?
Actually, it is the decision about off-clamp is based on two clinical factors. So that can be studied as in a protocol, like maybe based on the single kidney multiple tumors where we may attempt to reduce the ischemia, or like Rajesh has told, like in an already compromised kidney to reduce the ischemia. These are the patients on which we may attempt a off-clamp. Otherwise, there is no benefit. So the standard of care, which is clamping, may not be changed with this study. And probably in selected patients, there is a role if the surgeon feels that it is possible to attempt like multiple tumors if you want to, these two sections.
Anup sir. Yes.
It's not the question of off-clamping and the with clamps. There is also selective clamping and super selective clamping.
Yeah, I discussed
so that point has to be kept in the mind. If required, though, you can do a super selective clamping
yes.
also, not necessarily do a total renal artery.
Yes. I'll discuss that in a minute, sir.
Can I make a comment?
Yes.
See, Ginil, I think, most of us in India, and for that matter, even on the data we have seen, 200 were the off-clamp, 2000 was the use of a clamp. I don't think many of us have trained, seen, or learned how to do a proper off-clamp. There are many videos which are available, and we have had some interactions with people who regularly do it, and they swear by it. They have never done a hydro dissection at all. They go straight for the tumor. They have two suctions with a very, very trained bedside assistant. And with the help of those two additional arms there, they're able to achieve 500 to 700 blood loss in the most complex tumors. So when we talk, this is an indication, this is not an indication, I think all that bias is coming from our practice where we are doing a clamp. And in few instances, we'll choose not to use a clamp. The reason is we are not trained enough on an off-clamp technique.
No, where is the actual benefit is the question. Whether it is improving the margin, where it is improving the GFR post-op, where it is going to benefit. That answer nobody could give till now. And these two studies actually maybe, even though the study is not a properly, like it is a retrospective analysis, data analysis, there are a lot of bias. That also tells the same truth, like why it is done, we couldn't done.
That's what I'm trying to say. Even here, you see, it's a propensity match trial. 200 you cannot match to 2000. It has to be propensity match. That's what I'm trying to say. We don't have data. We don't have experience.
No, Gopal Sharma's was actually a propensity match.
It was propensity. Yeah. Anup sir, the T stage of the tumor and complexity scores were not matched in both the studies. It is actually very difficult to do that, especially in a retrospective setting. Do you think that this could have caused the interpretation as what we see today?
This is a norm that normally the surgeons will choose a simpler case for off-clamp and a complex case for clamp. This is like a normal practice all over the world. I have seen many experienced surgeons across the world doing only off-clamp, but then for selected patients. So this is a definite case for biased interpretation. If you go head to head, apples to apples, definitely I feel off-clamp will not have major advantage over the clamp technique.
Yeah, I'm just trying to build up a case for off clamp. So that's why all these questions. Now, if you look at the papers in detail, there was a 10.2% conversion to radical nephrectomy, which is according to me sacrilege, compared to 1% on clamp. So that again is a strong indicator as to why we should not be doing an off clamp technique, indiscriminately, and we should really use it in selective cases. So, sir, that's why I was asking all these questions.
No.
The answer is no. Okay, so we should not be attempting an RCT, because I think, personally, I think that was your next question. RCT is very difficult to do, considering that patients come in different cohorts. So it is extremely challenging to do a RCT in this setting.
Should not be doing an RCT.
Yes. So that, Ginil sir, this question is for you. If you wanted to really do, you said, you wanted to do it in a few cases. Do you adopt any specific surgical steps for the benefit of the...
Actually, day before yesterday, I had done an off-clamp, even though I was against off-clamp because it's a multiple tumor VHL. The thing is, what we are doing is we'll just dissect and keep the blood vessel ready for clamping and keep the clamps inside in case if there is a bleeding to clamp. Then we proceed step by step, clip small vessels inside and proceed with the thing. And at any point we feel that it is risky for the patient, or because of the visual things, I may go into a tumor. If the field is not clean, I just clamp and finish it off. That is what I usually do, so that I can reduce the...
So basically you are trying to minimize the ischemia.
Minimize the ischemia and if possible to proceed.
Yeah. Sir, anybody else, any other inputs on how you would probably do an off-clamp technique?
So we have done quite a few off-clamp, but only selected patients. As Ginil said, it is very selected patient. That will be the next question. I will discuss the indication. But yes, we always do the hyalid dissection, keep the vessel loops under control. And if we feel the bleeding is too much, we are not hesitant to go for clamping. But till date, if you select your patients carefully, you don't have to clamp. So it's clearly selected patients. You should do a good hyalid dissection. You should have a proper vascular control. Then the rest of the steps are almost same. Except that what Ginil said, if you see vessels, you're doing robotic, you can actually tie it or clamp it, put a slip over it so that you can take control of the bleeders. So that you can do. This we do in the normal clamp technique also.
Kashyapi sir, in the past, we know when we were training, we were taught that, if you are doing an off-clamp technique for a small polar tumor, you can actually compress the parenchyma with 2 fingers and then do the resection of the tumor. But then there were a couple of papers which showed that, just applying additional pressure on the parenchyma of the kidney can cause equal amount of nephron loss as would have been caused by clamping the kidney. Do you agree or do you disagree, sir?
I think we don't do that.
Yeah, we don't do that.
We don't do that.
Yeah. So again, just a message for the youngsters that, compression of the kidney as a part of off-clamp resection of the tumor may not be a good idea. So there are several hybrid strategies for on-clamp technique to minimize the ischemia time. We can clamp the artery only. We can do selective arterial, like Gupta sir was mentioning, selective arterial clamping or super selective arterial clamping. We can actually release the arterial clamp early as soon as the control is done and then complete the remainder of the procedure. And then we can also do a cooling of the kidney. What was typically done in the open is also now possible with minimal invasive techniques. And I will discuss about it in a while. So Anup sir, if at all, I think you have already answered this. If at all there is an ideal index case for off clamp, is it a hilar tumor or is it a polar tumor?
So it's a polar tumor less than 4 centimeter and it's exophytic. These three criteria we are meeting, then you can think of doing the off clamp technique. And of course, then what Dr. Ginil said, especially if you have a CKD and multiple tumors, I will add to it.
Ginil sir, would you like to attempt off clamp for hilar?
There are two approaches for hilar and midline. Like if it is a midline, you usually dissect the hilum and get the selective clamping of the feeding vessel if possible. Then I just remove. In the polar, I will be just clipping the vessel that is feeding and proceeding in the off clamp.
So the hilar tumors will probably have 1 or 2 well-defined feeders compared to a polar tumor, which might have feeding channels from multiple sources. So the technique has to be different if you are dealing with a hilar tumor off clamp compared to what you would probably deal if it's a polar tumor.
Basically, typically speaking, if you want to go for typical off clamp, then hilar tumor should not be attempted, because if you are going for clamping this vessel which is going to the tumor, that is a super selective clamp. So this is not typically off clamp. Off clamp means you are not clipping any vessel at all. So what you are saying is super selective clamp. So if you off clamp means you are not touching at all the vessel. But that is not possible for hilar tumors. I mean, this is what I want to give the message. But yes, experts can do, they can try, but it's really dangerous for the surgeon, the patient.
Ginil sir, how important is it for you to have the additional gadgets like Firefly or drop-in ultrasound? If you
I usually, or for almost all the patients, I use these two, because Firefly is not to assess the tumor, but to confirm that the vessels are properly clamped. Because sometimes if there is any tissue in between the vessel, it may not be properly clamped. To assess that.
No, I'm talking for off-clamp technique.
Off-clamp, I am not using Firefly for this one, because I just check Firefly only for just assessing whether the clamping is proper. What is the other question?
That's it. Yeah. So I found this very interesting article which was published in 2023, a series of 10 patients where they have done intraoperative intra-arterial cooling of the kidney. Typically, these were the 10 cases that they have done, typically very complex tumors or multiple renal tumors, and they found out that it is possible to do it. Of course, only 10 cases have been reported, but that's the first in series. Then there was also a trial which showed that super selective ischemia, that is super selective clamping of the renal artery, did not actually provide better long-term renal function than complete renal arterial clamping. Though technically we feel that the rest of the kidney is definitely well perfused, super selective should technically be better. The trial, however, has not found any additional benefit of that. I'll just skip this. This was the third study, the Robocop 2 study, which compared the open and robotic, the feasibility of doing a RCT between open and robotic partial nephrectomy. They found out that it was feasible to do it. I'll go with Ginil Kumar sir again. Sir, can we consider, we don't have an RCT, but we have done, a lot of people have done for many years now robotic partial nephrectomy very well with good outcomes. Is it time that we consider that as the standard of care, or we definitely require an RCT?
Open and robotic are for entirely different two categories now, as far as I'm concerned. Open is only for those patients who are not able to afford or is too complex that there can be. So an RCT may not answer this question. So as far as this is not there, my first preference will be if it is possible to go for a partial. So it doesn't have any clinical relevance in the current scenario.
Kashyapi sir, they say they have done a feasibility study, and do you really think it is feasible?
It is feasible, but you need to study. Ginil mentioned both have different indications. Why do you need a feasibility study at all?
Not required.
And why do you need a RCT at all? No.
So there are several challenges to actually do a trial of this sort. I'm just skipping it for the want of time. Kashyapi sir again. So there are so many things happening in this arena. For the youngsters, if you feel that because there are so many trials happening, they may not have any clinical relevance at all. So in the realm of doing a partial nephrectomy, what are the unmet needs, and where should we look at if we really have to conduct some good trials?
I think what needs to be understood, if somebody's tumor is suitable for a partial, it should be done partial. You should be able to offer a partial, whether you do robotic.
No, sir. From a trial perspective, what are the unmet needs do we have?
See, again, there is no benefit of a clamp or off clamp. That is also not true. So I don't think there are much any unmet needs. No, you may get some new tools which will help you identifying the margins, the vessel, where you may look at.
Okay, I will take 2 more minutes. One paper to be studied. This was the cancer-specific mortality of T1A renal carcinoma treated with local tumor destruction. There was definitely a higher cancer-specific mortality, especially more pronounced when the tumor size started increasing. There were several limitations to this study. There were a lot of debate on local tumor destruction, but not much data is available. Only 8 meta-analyses available, only 1 RCT. Most of them are focused on technique complications. We do not have cancer-specific or overall survival data long-term as yet. And this was the point that I wanted to discuss, the SBRT in small renal masses. This study reports 5-year cumulative local failure rate of 5.5% and a 7-year cumulative local failure rate of 8.4%. However, the critical points were the cancer-specific survival, the metastasis-free survival, or the overall survival have not been assessed. And it is not reported as an outcome measure in this paper. The duration of follow-up is also small. So, very quickly, last few set of questions. Anup sir, will you ever consider ablation in a T1A for a fit patient?
Not for a surgically fit patient. Of course, these days patients, they come up with other options and I give them options. Suppose patients say, I don't want to undergo surgery, even if he's fit for surgery, then that option, I can explain to him giving the pros and cons, but this will not be my first option. So in my opinion, I will not offer local tumor destruction for T1A, which is fit for the surgery.
Ginil sir, any role of ablation in
stereotactic or RFA?
Any ablation.
So these are the patient who is not fit for surgery. As Anup, the same answer. If it is eligible for a surgery, I will go for a surgery. Otherwise, active surveillance or ablation, which one our patient is.
Madam, this is for you. Do you think we have adequate data for SBRT now in RCC, especially T1A tumors?
Till now, we do not have any randomized control trial that compares surgery versus SBRT. So, patients who are taken up for SBRT are only those who are not suitable for surgery and otherwise having poor surgical candidates or poor prognostic features. So, maybe as of now, surgery should be the primary treatment until we have randomized data.
Yeah. So, this is another interesting concept that I was reading. Now people are now offering radiotherapy SBRT to the primary and following it up with immunotherapy or vice versa. Give immunotherapy in patients who have had favorable response, do SBRT. They find that the abscopal effect of the tumor is pronounced or enhanced when you offer radiation to the primary. What is your take on it?
So cytoreductive nephrectomy or cytoreductive treatment is not a new thing. It was routinely done in the interferon era, but it was not done in the, it is not frequently done in the immunotherapy era. But SBRT has another advantage that it has immunomodulator effect and which expose more antigen, more cell-mediated immunity. So in those cases, maybe if we if SBRT is followed by immunotherapy, maybe immunotherapy will be patient will be having better response to immunotherapy. So there are few randomized control trials that are comparing SBRT followed by immunotherapy versus immunotherapy alone. So definitely this has the potential to improve outcome. So maybe.
Sir, will you send a patient who's responding well on immunotherapy to madam for radiation?
Quite tricky situation, sir, but yeah, this looks attractive and we need to generate robust data before we start using this.
Yeah.
As of now, no, sir.
Last word from Kashyapi, sir. Sir, do you think amongst all this, you still want to fall back on active surveillance wherever possible?
Yeah, wherever possible, yes.
Even for T1B tumors?
Not for T1B, T1A, smaller
T1A,
tumors.
only small renal
Smaller
mass.
tumors.
Small.
Larger tumors, if they wish a treatment and not willing for a surgical option, primary surgery. If they are not willing for a surgical option, all these options are taken.
So would you place active surveillance above these ablative options, or would you want to place active surveillance below the ablative options?
T1A.
Surveillance. Yeah, with this, I think we will conclude. Thank you very much, panelists.